Hi, welcome back to Expect More with Dr. Andrea. Today, one of my very good friends in the journey that I've had in physical therapy, Dr. Zach Dunkle. Zach, if you don't mind, can you introduce yourself and a little bit of your background, please?
My name is Zach. I'm a physical therapist. I have a board certification in orthopedics. I work in a small private practice down in Atlanta, Georgia. And in addition to treating people in the clinic, I teach blood flow restriction courses. I've been doing that for almost 8 years, I think, something like that. So I started doing it in June of 2017, and I've been doing that ever since.
Welcome to Expect More with Dr. Andrea, the podcast where we cut through the noise and get real about healthcare, physical therapy, and what it means to truly take charge of your health in today's ever-changing world. I'm Dr. Andrea Davis, physical therapist, straight shooter, and your go-to for no-fluff conversations that challenge the status quo. From the front lines of patient care to the big picture changes in the system, we're diving into what's working, what's not, and how you can expect more for yourself, your care, and your life. Real talk, real solutions, no settling. Let's get into it. You're a beast. Don't tell the other boys, but you definitely are our favorite for sure. Love running into you at conferences and, speaking and spreading the good word of restricted blood flow. It's a game changer for me, for sure. When we came across it, and then I had been to teach, so it was okay, but no, I'm just kidding. Ben's awesome, but it's been game changer for our industry. The fact that we still have some naysayers out there about restricted blood flow is disappointing. But yeah, I don't know if you want to speak to that maybe a little bit.
Yeah,
Hot topic.
yeah. I think there's a couple issues, so to speak. If you've been in and around physical therapy for a long enough period of time, you've seen the latest and greatest, right? And then it's after a couple years, it's like what does this actually really do, type of a thing. But I always tell people the really big difference with BFR is when it comes to the evidence that we have, it is not like the evidence of really any other intervention that you have within physical therapy. We have good hard science that substantiates what we're doing. What we think we're manipulating is actually what we're manipulating. What we think we're addressing or changing to produce this change in muscle is we actually are doing that. And when I say the science behind it, I mean, we're talking pretty hard science.
Agreed.
You not just looking at the overall change in muscle mass with just taking a tape measure and wrapping it around the limb and seeing, oh, well, yeah, it's got larger. No, I mean, we're talking about actually doing a biopsy of a muscle and looking at morphologic changes within that and genetic markers that are changing through a training period. And then when we talk about resistance training in general, high load training is the gold standard. I mean, we've known that for the longest time, that you lift a heavy weight, the muscle's going to respond. Well, when we compare BFR to high load training, we tend to get like pretty comparable results. Now, absolute strength changes will always tend to favor high load training, but when you look at confidence intervals and whatnot, with review papers and meta-analyses and things like that statistically look at this, BFR produces pretty comparable results to high load strength training. And so, I think in the context of what we do as physical therapists, it offers a really good opportunity to get after things very quickly. I just did a course yesterday, and when I talk about the disuse effects with muscle, we're not even really talking strictly looking at, surgery or trauma or things like that. I mean, we're literally talking about someone who hurts themselves and then they get on the internet and the internet says, oh, you just need to rice it. And when you rest it, magic happens. And then in 2 weeks, like everything's better. And it's really not, and if in the context of muscle, we're actually probably worse off following this rest period than what we were before we even did the rest period right after the injury. And so what BFR allows us to do is really start getting after things, working with the muscle issue, because that's the thing that we see change extremely fast. We can do this in the presence of pain while the tissue's healing. We can produce this hypoalgesic effect or analgesic effect, reduce the perception of pain while they're exercising when they would otherwise be limited performing high load exercise. And that's really the big deal. So, the conversation about BFR low load versus versus a high load exercise. Yeah. Like when you look at healthy people going to the gym, like 100%, why do you want to do BFR? Like I get that. But in the context of a clinical situation coming off of an injury, or, if you work in orthopedics or sports medicine coming off of a surgery, it could be something as common and frequent that we see in ACL reconstruction. It could be a meniscus repair, or it could be a combination of those two things. And when you start increasing the complexity of the surgery, you're ultimately, what that means to us on the rehab side of things is you're going to prolong weight bearing status. That's what that really translates to. Yep. And so I always tell people, like, you have guidelines from the American College of Sports Medicine that says, like, if you want to increase muscle mass and strength, you just need to lift to 75, 85% of a 1RM. But the big problem with that is, how are you going to lift at 75, 85% of a 1RM when someone who is 1 to 2 days post-op from a meniscus repair, who's non-weight bearing, limited weight bearing, modified weight bearing for 5 weeks, 6 weeks, and then they also had an ACL reconstruction? You're really limited with what you can do.
Can't do anything, really. I mean, we go through this all the time in the clinic, and people are so afraid, Zach, to like throw the cuff on like post-op day one that I still don't get it.
Yeah, so that's really the big benefit. And and here's, when it comes to the science of things, like one of the things that I always tell people, if you're really limited, like if you cannot do anything else, like that really acute post-op, because it's like we can't even do a straight leg raise. Like this person cannot do a straight leg raise. And I'm like, okay, throw the cuff on and just go through this inflation deflation protocol and put some stim on it. Do as much active exercise as you can. So whether that be like hip abduction, hip extension, straight leg raise, adduction, all that stuff, whatever you can do, you do that. And then at the end of the session, put the cuff on and you go through this inflation deflation protocol with some neuromuscular stim to the quad. And then, we can kind of start jump starting this process. And the great thing about the cuff, when we start combining it with neuromuscular stim, it's very similar effect that we get with resistance training. And what I mean when I say that is, we don't need a high intensity of stim, because that's one of the big limitations to stim with people is
tolerance.
Yeah. Like I did a course at the University of Delaware back in 2019. Yeah, 2019. And we got to talking about stim, and they're really big stim gurus there. And they said we stim at 60% of MBIC. So they basically test them. They push into an isometric strength test, and then they will stim at 60% of whatever that individual produced. Okay. That's somewhat intense, right? And then what we see with research with BFR is we can get a favorable effect. We can get a good muscle change by stimming the muscle at 10 to 15% of that maximal isometric contraction. So we lower the intensity to produce the favorable response. And then the other thing that we see too is when we talk about this research and whatnot, there was a paper that was done. It was published in the spring of 2020, I believe. And they literally took muscle biopsies. They cast immobilized individuals basically from the ankle to above the knee. And then they collected muscle biopsies at baseline, 1 day into the immobilization period, 7 days into the immobilization period, and then after 14 days of immobilization. And we actually were able to see that BFR was able to suppress some of the rise of certain genetic markers that contribute to the breakdown of muscle proteins and ultimately contribute to atrophy. So long story short, like in general terms, like what's going on is we're putting the brakes on the atrophying process in that really acute phase. That is the key. What we see going on when someone goes into a disuse state, whether that's just a self-imposed like rest, whether that's an injury such as an ACL tear or that's surgery, what we see is atrophy really peaks within the first 2 to 3 weeks. And after that point in time, it just plateaus off. And the amount of atrophy that we have is really what we're left with. I always tell people in the context of ACLs, there was a paper that was recently published from the University of Kentucky. And what they actually showed was at a median time point of 21 days post ACL tear. So literally, this is just tearing the ACL. This is not surgery. This is literally tear the ACL. At a median time point of 3 weeks, we see an 8% atrophy on the ACL torn limb in the quad compared to the contralateral side. And so, like, that's the deal. These changes occur extremely fast, and we have to find ways to address this.
Well, and like education is a big part of it, because people don't know what they don't know, which is a big part of why, having you on here to discuss this. One of my favorite things about Owen's Recovery Science is all the complicated sciencey stuff is stripped down so well and fed to us as clinicians in a manageable way that we can digest it, but then it's actually easier to then explain it to our patient population, because you got muscle wasting. They come in with the skinny quad. If we're talking about ACLs, they come in with a skinny quad, and it's called chicken leg. Really, you come in with the chicken leg, and you want to beef that guy up quickly. And if we could get these, like, I had a kid that waited I think 3 months to get surgery and no prehab. So now you're talking about that wasting ahead of time, and on top of the contralateral side now that is also wasting. So, paying attention to that time frame is massive. And if we could get them in sooner, I think for prehab, I think it would be extremely beneficial.
Yeah. So there was actually a paper that did it. And here's the thing too, with BFR, the nice thing is we get some good changes in muscle pretty quickly. And so Alan Kaysen was the lead researcher. It was out of his group. And what they did was they brought people in who had already torn their ACL, and then planned to go get surgery. They brought them in for 9 sessions over a 3-week period. Separate them largely, we'll say, into 2 groups. So we have a sham group that we're just going to put a tourniquet on and inflate that thing to 20 millimeters of mercury. So there's going to be no real stimulus here. You're just going to perform leg extensions and a leg curl. So an exercise directly hitting the quad and then one hitting the hamstring. It's going to be loaded at 40% of their 1RM. And then we're going to have a BFR group. We're going to inflate that cuff to 150 millimeters of mercury and then do the same exact exercise, 40% 1RM leg extension, leg curl. And then after these 9 sessions, we're going to isokinetic test them. So we're going to test them at 60 degrees per second, which is pretty much the standard for low speed isokinetic testing. There was a 14% increase in isokinetic testing at 60 degrees per second. There was a 5% increase in muscle mass. This is after 3 weeks of work. So yeah, like I always, when we talk about an ACL tear, I always tell people the quad takes 2 hits. The initial hit is the tear and the subsequent atrophy that we get. The second hit is the surgery. You want to try to normalize this as much as you can going into the surgery. We see there's a growth factor that is upregulated as well. And it's a negative regulator of muscle growth, meaning that, just for anyone listening, when this growth factor is kind of turned on, think of it as a light switch. When that light switch is on, muscle growth is actually turned off. It inhibits muscle growth. The other thing that we see too is this growth factor contributes to a lot of fibrosis within the muscle. And think of collagen, think of this.
Scar tissue.
That's exactly what it is. Yep. And this is the crazy thing. This is not a systemic wide change. It is only happening on the involved side. And I tell folks, I'm like, we're getting a lot of good emerging research about what is going on with ACLs. And it's a lot better than simply just saying like limb symmetry index or quad strength is off at 6 months. It's off at 9 months. It's muscle mass is down. So that's all great to make that observation. But now we're starting to get some good research, and it shows why this is going on and what the problem is that we're having. So I think
like in a more granular level, right? Like it's getting deeper. Like the surface stuff is easy. You can see it. We've known it 20 some years, however long we've been practicing. But that biohacking, if we can use that term a little bit, is manipulating the science to try and produce the amicable results that you want.
Yeah. I always tell people, and like, Johnny and Kyle and Ben always laugh and joke around with me, but like I look at things at a very mechanistic level, because I truly believe if we can find out what is going on to drive a process, we can find interventions. Like the big challenge is ultimately finding out what is going on. And once we find that out, I really think we can, whether that be with an exercise or with a drug, whatever, I really believe that we can then find targeted therapeutics to address the issue.
And if you can get to it, it's like anything else. If you get to it at the root of the problem, right, that's essentially what you're saying.
Yeah.
You want to strip it all the way down, the way down, get to the root of the problem, and then start addressing the root of the problem as soon as you possibly can. And on your highly intelligent side of things, it would be miraculous to us lay people, me just regular PT people, to be able to even accelerate our processes more than we already are.
Yeah, and I always tell people, when it comes to muscle, the maintenance of muscle, we just look at things. It's very simple. It's a simple mathematical equation, right? So your muscle is the net protein balance within your body. So it's all your proteins are in muscle. That's where they're stored. That is equal to this how much we're making of proteins minus the breakdown of these proteins. And so to grow muscle, it's really simple. You have to have a net gain of these proteins. We would then build muscle. The tricky part is when you go into those disuse states, coming off an ACL tear, things like that, it's how we stimulate the process of building or synthesizing and making those proteins. That's the trick. And so,
and the nutrition contributes to it as well, right? Because we get that question a lot. And how much more protein do I need to intake? Like we used to give that speech a lot when we initiated things. That's still true, correct? Like if you up your nutrition goals a little bit.
Yeah, and that's something else too. Is I always have a conversation with patients. I'm like, dude, like you're doing the hard work in here. Like, make sure you get an adequate amount of protein. That's like low hanging fruit. I mean, that's the easy stuff. So, and by low hanging fruit, like I tell folks, make sure like how much do you? Because everyone will tell you, I take in a lot of protein. I eat a lot of meat. Whatever. Yeah. I'm like, well, how much are you eating? And so, and I was like, how much do you weigh? And they'd tell me a weight, and I'm like, you need that many grams of protein. Just make it simple. Don't worry about how many grams in a meal. Don't worry about any of that. Take the amount that you weigh, put that in grams. So if it's 130 pounds, you need to take in 130 grams of protein. Then how often do you eat a day? If it's 4 times, then just divide that evenly. Just say 130 divided by 4, and that's how much protein we're going to take in per meal. And then the other, there's actually
so simple.
Yeah,
so smart yet so simple.
And here's the thing: is there's research that supports this. Like coming off of a total knee, like literally everybody does the same exact rehab. One group just supplements with some amino acids, and they have significantly less atrophy in the leg. I'm like, this is the easy stuff. And so the other thing that I'll tell people to do too is take creatine. If you look at research, just supplement research out there, there's 2 supplements that have the most efficacy to them. It's protein and creatine. And then, a lot of the early research with creatine was strictly on the muscle side of things. But man, we see so much now, like favorable benefit on the cognitive effects of creatine, that, I mean, like it, honestly, everybody should be taking creatine.
I started about a month ago or whatever. And, it's just part of my routine now. Scoop it up.
Yeah. And here's the thing too, is, creatine is honestly pretty cheap. But yeah,
it's pretty, we'll edit this out, but there we go. All right. You're doing great.
Yeah.
So smart, a lot of information. All right. Let's move on to let's talk sports. So Zach, let's talk sports a little bit, and we'll talk about I get the question a lot. I'm in season, I don't need to do blood flow, and we see a ton of pitchers. I mean, I played softball and coached softball for years and years. So my daughter's a pitcher, she's a freshman, and we're still doing blood flow even though she's in season. Can you kind of touch on that a little bit, because we have some clinicians, not here necessarily, but clinicians that have reached out and said, Andrea, do I do this in season, or it's an automatic shutdown in season with blood flow, which I find to be silly. But
yeah, I think you can look at this a couple different ways. First, I'm a huge proponent of lifting. If you can lift heavy loads, lift heavy loads. And that's what you want to do. Here's the challenge when we talk about an in-season athlete. You have to take a look at how many games are they playing within a week. And then I think sometimes, whether it's a strength coach or it's a PT that's, working with teams and stuff. And, you kind of can get lost, so to speak, because you have this centric approach of performance. And how do we get performance? Well, we have to continue to train. The competition is the product of training. But what you have to realize is if the kid's playing baseball, they're a baseball player. If your daughter's playing softball, she's a softball player. She's not an Olympic weightlifter.
Correct.
So what the weight room does is it helps to produce the product on the field. It supplements, it creates what we see on the field. Like, these people are not Olympic lifters. They're not power lifters. And sometimes we get lost in that, and you have to step back and think, what you don't want to do is you don't want the weight room to detract from the playing. The playing is what that kid is doing. And the only reason they're doing the weight room is to help them get better playing. They're not playing baseball to help them get better in the weight room. Like that, you have to think about that and put that into context. So with that said, I think, again, I'll step back and I'll say, if that person can lift heavy and if the schedule allows, lift heavy, absolutely. However, if you start playing tournaments or you start playing series or you're traveling, the last thing that you want to do is do heavy resistance training that's going to further run you down. And so from there, I think BFR might have a role, specifically because what we see is we can do a session of BFR and we can hit things and we can get a nice effective session in relatively quickly with minimal overall stress to the body. In fact, when you look at the BFR studies, some of the early studies, they're doing this multiple times a day on a daily basis. And we still see at the end of that training period, strength significantly increases. So all that to say is we're not going to produce a significant amount of stress to the body or fatigue. And so we can still allow them to compete. The other thing that we can do too, when you talk about certain positions, such as pitching, for example, a lot of what pitchers will do within the major leagues is they will use BFR as part of their arm care. And this is this is somewhat, it's an individualized thing. It's not all inclusive and everybody does it. I can tell you that there is a ton of pitchers that do this. In fact, one of the teams that I'm somewhat close with, their pitcher specifically, and in fact, this was a few years ago, this team went to the playoffs. The PT reached out to me. He's like, hey, man, can we get a couple extra units? And I said, yeah. I said, whatever you need, buddy. I said, hey,
I'll send you a whole
whatever
case.
you need to beat this team that's in Pennsylvania, we will do it.
Oh, no, I said,
we'll do it. We'll do it, whatever you need. And they said,
didn't happen.
They said,
gotcha.
They said, we have our outfielders really love this. And I said, so this is the reason that we have one player that steals a whole lot of bases. And they said, well, the pitcher really wants to do it, but the machines are all tied up. And I said, okay, let me know what we need. I said that.
All right.
I said that guy can get as many units as he would like. So either way, like
as long as he serves the strikeouts up, right? Yeah.
And so all joking aside, guys, one of the biggest kind of reports back that people will give is they just feel fresh. Like they don't feel run down when they do BFR. Like they do a session, they hit it hard. Like you feel like smoked while you're doing it, but you have no lingering deficits. And I would say that's the big thing. And especially when we start talking about these high level individuals, so like the major league players, here's the deal, because people always joke around and they're like, you mean to tell me that the center fielder who's just standing out there needs to do some recovery?
Right.
It's not how much they're running in the game. Tell me another sport that someone's going to compete 23 times or 21 times in 23 days. It doesn't happen. And then the other thing of it is too, is you can't just look at this in the context of like what's going on in the game. Dude, you're traveling on top of this. And so you're going to go, you got a 3 or a 4 game series, and then you're out. After that last game, you're flying to the next city and you're going to play the next day. And then you're going to do this for a couple weeks without rest, or maybe with just 1 day rest. It's a brutal, like Major League Baseball is a brutal season. The season is long.
It is.
And the schedule is long. It's grueling. So that would be the benefit. So someone who, is really, they're competing a lot, but you still want to kind of at least maintain strength through this competitive season.
Well, I mean, I think that's why a good portion of it is why we see, I mean, we could talk probably another 3 hours about the state of youth sports just in general with, tournament play in season, right? So they're 12 months out of the year. The way we look at things, at least in the office, is anytime I'm doing an athletic evaluation, we talk about athlete management, right? So then we're like, January to December, tell me what your life is like. Obviously you have school, but tell me, are you tournaments? Are you club team? Are you multiple practices? Give me your workload for that week. And what I'm taking away from this is even at the high school and collegiate level, recovery, blood flow has a place in the recovery portion that some of us are missing the mark with, that we could be implementing. Now it comes down to their time, right? Our time, cost, and all the things, but we could be putting out this, recovery plan, which we've started getting into significantly, but it's highly individualized, like you said, right?
Yeah. So, and that's the thing too. So, we've just literally talked about BFR resistance exercise. So one of the things that we do see, and we have some pretty good data on exercise data, as well as semi-professional soccer players. They do a passive protocol. And what it does is it actually expedites the recovery process. The exercise studies that have been done, they test muscle force generation, which is that's probably the most important measure to test, because if you look at what does muscle do, it generates force. It's all that it does, really.
That's right.
So when you go from a reduction in force because of the muscles fatigue, damaged, whatever, after a workout session or after competing, and then we can restore that back to baseline 24 hours sooner, that's going to be a win for us, because now that individual, if we're in a competitive season, they're back to baseline. They're able to compete completely fresh compared to if they just, did the wait and see approach. And we see that too. There was a paper with semi-professional soccer players, did the same thing, like this recovery protocol, and we see sprint speed was unchanged versus a drop in sprint speed or an increase in duration to do like a 20 meter sprint. Counter movement jump didn't change. So all these metrics that now moving outside of like this, just strictly looking at muscle force, now we're looking at actual what is relevant to an athlete. So more sport specific things, explosive strength and counter movement jump, your ability to sprint, like all that stuff, it doesn't change. So like we're there where we need to be to compete again, where we're there. So That's the
Well,
deal.
I mean, to bring it back to like the center fielder, right? So yes, like I get it a lot that he just oh, softball, you just stand there type thing. Well, you stand there until you don't, really, right? So center fielder's got to be able to like kick it in
Yeah.
and read the ball off the, read the bat off the ball off the bat, and then be able to sprint to that target. So there is recovery that's needed to make sure that you're ready for that.
Yeah.
For sure.
Yeah. Yeah. It's
Good stuff.
yeah. So and that's the thing. And then again, like I can tell you and anybody that when it comes to professional team sports, the buzz right now is on recovery, and it's largely because of how games are getting packed in to the season and into the calendar. Like my oldest is a huge Inter Miami fan, so an MLS team, right?
Okay.
Huge, yeah. I mean, he's a huge messy guy, but dude, he's all about Suarez and all these other players. And so we watch a lot of Miami soccer. I will tell you that Miami has had an absolute grueling start to the season. Up until this past weekend, they were playing 3 games a week. And like
that's a lot.
Yeah, when you're talking about literally running and sprinting upwards of 8 to 10 miles in 90 minutes, it's grueling. And so you factor all that in, and now it's like, well, how can we get this guy from a Saturday match to a Wednesday or Thursday match? How can we get them back to baseline? And then after that Wednesday, Thursday match, how can we get them back to baseline for the Saturday match? I mean, like it's brutal. And so that's the name of the game right now.
Yeah, I mean, it's the levels changes, right? Because what you do for recovery with a 4-day stretch may be different, totally different than what you do for a 2-day stretch versus a 10-day stretch. So, and knowing what's taxed and the athlete, there's a lot of maturity. I mean, the upside of working with the pros is that they understand their bodies much better than high school kids, and they're, intelligent in ways that are difficult in college and high school. And we've just kind of started talking about it like within our profession. I think if we start teaching younger how to be advocates for themselves and the difference between hurt, are you hurt or are you injured? But like, being truly hurt or just dinged up a little bit and you're sore. Yeah. But it's hard because the younger they are, the maturity levels just, they're not quite there yet.
Yeah.
Some are, but not all. There's awesome stuff, Zach. Thank you so much.
Yeah.
I appreciate your time, man. It's where can anybody if they have questions or whatnot, where can we get a hold of you? I mean, I know how to get a hold of you, but
yeah, you can either reach out email wise is ZP Dunkle DUNKLE at Owens Recovery Sciences, where I'm at with that. And then Owens Recovery Science has we like to put out a lot of good information.
You do. Yeah, it's amazing.
So we have a podcast as well. We write blogs. So we just put out a lot of content for people, and it's crazy because I literally have had people come into the clinic that like don't know me at all, and they come in. We do an eval, like ACL stuff, and they'll be like, "Man, like, dude, I read this blog. It's a blog I wrote, and I'm like, well, was it worthwhile?
Was it any good? Exactly.
Was it worthwhile? Yeah.
Was it intelligent?
But yeah, so we do that, and I would say like
you do an amazing job of it. Well, really, truly, it's like my favorite group of guys, hands down. Yeah, and you at the top.
We try to like put different stuff out there that you don't get with just a normal physical therapy type deal. So
it's and I think the way you do it too is manageable for both clinic minds like myself and my colleagues, but also for the general public, like to be able to put it in layman terms. Like I said, some of this stuff can get a little bit deep and technical, but you guys do an amazing job, I think, of breaking that down and putting it out there. So Thank you.
Thanks.
Yeah, you got it. Dr. Zach Dunkle. Peace out.
Well, one last thing.
Yeah,
Andrea.
Go for it. Yes, please.
Let Antoinette know.
Here we go.
Let her know that when I was out in San Diego the other Friday, There was no snipers in the streets. I had good Overwatch. There was no snipers in the streets. Okay.
Oh my God. Whatever. I swear to God, I'm never going to live that down. Ever live that down. This piece of work. Yeah, that's all right. That's the last time I wore those boots too, by the way. Cobblestone got me good. Oh man. Well, thank you, sir.
All right.
Peace out.
That's a wrap on this episode of Expect More with Dr. Andrea. I hope you're walking away with something real, something that challenges how you think about your health, your care, and what you deserve. If today's episode hit home, share it, leave a review, and make sure you're subscribed so you never miss the real talk. Because in a world that keeps shifting, one thing's constant. You should always expect more from your providers, your movement, and yourself. Until next time, keep showing up, keep asking questions, and never settle.